So welcome to the Osteoarthritis Action Alliance Lunch and Learn for December 2015. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join the webinar today. I am pleased to introduce our presenter, Dr. Jeffrey Katz. Dr. Katz is a professor of medicine and orthopedic surgery at Harvard Medical School and the director of Orthopedic and Arthritis Center for Outcomes Research, or OraCore, at Brigham and Women's Hospital. His research interests include epidemiology, health services research, outcomes, joint replacement, and spine surgery. Dr. Katz is especially interested in musculoskeletal disorders such as osteoarthritis, regional pain, and others which account for an enormous burden of pain, functional loss, and productivity loss. Today, he will speak about Arthroplasty Outcomes 2015. Welcome, Dr. Katz.
Thanks very much, Kristen, and I'll go right ahead. If anyone has any problem hearing me or with the slides, just sort of send in a question and Kristen will be able to let me know that. And so this is just a disclosure slide. Most of my work is supported by NIH. So I thought what might be useful would be to provide a framework for understanding the outcomes of hip and knee replacement and to review evidence about risk factors for poor outcomes. And I think more generally, and I thought this would probably be useful to you in the work that you do, to answer questions that patients with advanced hip and knee OA often ask about total joint replacement. So I have here a list of frequently asked questions that I think are culled from the experience of that I've had and that many colleagues of mine. Patients will ask, am I ready for joint replacement? Shall I have it now or shall I wait? What are the alternatives? What's the risk of death and complications? How likely will it relieve my pain, and what level of physical function can I expect after a joint replacement? Once I have the implant, what are the challenges of living with an implant? How long is it going to last, and will I need another, and when would I need another? So that's not an exhaustive list, but I think a good list of frequently asked questions. And so what I'll do is walk through what I'll describe as three periods: the perioperative period, including the admission in the first several months, the quote-unquote honeymoon period, 1 to 10 years or so after joint replacement, where patients have generally achieved maximal benefits, and the things that we're interested are functional status and pain relief, as well as some complications like infection and dislocation and fracture. And then over the longer term, where we start to look at symptomatic failure of the implant, the need for revision, and there continue to be risks of infection and fracture and dislocation for the hips. So starting in the perioperative period, one of the things that patients really want to know, and that family members and as physicians and clinicians, therapists, we want to know is how likely patients are to die following these procedures. That's really a great and a legitimate fear. So here are some data that are summarized from several different studies that I list on the bottom of this slide. And I think you could sort of summarize these to yourself as saying that for hip and knee replacement, somewhere between 0.5% and 1% of people die within 90 days, more for hips than for knees. And for revisions, it's about twice as high, even 3 times. So 2 to 2.5% of people die in the first 90 days. And here's a list of risk factors for mortality. So death is more likely following hip replacement than following knee replacement. It's more likely following revision than primary. Not surprisingly, of course, it's more likely in older people, in males who have more cardiovascular comorbidity, in patients with lower socioeconomic status who generally have more comorbidities. Specific conditions include diabetes, cardiovascular disease, renal disease, dementia. African Americans face higher mortality rates, and irrespective of any of the patient factors, low volume hospitals and low volume surgeons are associated with higher mortality rates. Here's an interesting related piece of information which was published 10 years ago but continues to really be a provocative observation. This is a comparison of mortality or survival, basically, in patients who had hip replacement, which is the top part of the top curve with the lighter rectangles, and then controls in the Medicare population who did not have hip replacement. And survival is better by about 0.5%. No, excuse me, by about, so on the x-axis, the survival goes from 0.9 to 0.8 down to 0.7, which is about 70%. So you can see that survival is better in the hip replacement patients by about 5%. It's a non-trivial amount. And these data are adjusted for comorbidity, for age, and for sex, and it's conceivable that it was not possible to fully adjust them. So it may be that this is simply selection, meaning that people who undergo hip replacement are more healthy than those who don't, because you would not operate on somebody who had a life-threatening condition. But it's also possible that people that hip replacement does confer a survival benefit, and this is a sort of fascinating observation that remains the interpretation of which remains unclear, whether this is all confounding or whether there's truly a survival benefit. But that's an important and interesting question. Complications, so pulmonary embolus, this is following knee replacement, occurs in about just under 1%, myocardial infarction just over 1%, pneumonia just under 1%, and for hip replacement, these risks are very similar. Deep infection, you can see from this graph, is much more common following revision than following primary. It's more common following knees than hips. Males are more likely to have infections. People with RA, rheumatoid arthritis, more likely to have infection. Longer time in the operating room and lower surgeon volume are all associated with infection. And you can see that revision knees at 2%. This is a sizable proportion, because this is really a devastating complication. Here are some data on the relationship between volume and complications, and you can see that patients who are operated on in higher volume hospitals, which is the bright yellow, is the highest volume hospitals, as compared with the lowest volume hospitals on the left, which is the darkest bars. The highest volume hospitals are only they have only half the rate of mortality, much lower rate of mortality. Similarly with infection, and a little bit less dramatically so with dislocation and embolus. So volume really matters. So to summarize, the mortality following primary hip and knee replacement is between 0.5% and 1%. For revision, it's between 2 and 2.5%. And for pulmonary embolus, MI, pneumonia, deep infection, between 0.5 and 1% for primaries, a little bit more for revisions. Higher risks of mortality and complications are associated with revision, with low volume centers, with comorbidity, with older age, males, obesity, which I didn't show you, African American race, lower socioeconomic status. And then there is this observation that I shared that total hip replacement recipients have better survival than age-matched controls, and we don't know whether that is due to favorable selection or a salubrious effect of hip replacement on patient survival, and that remains an interesting question. So let's move to the honeymoon period. We just this fall, for the first time, have a randomized controlled trial that was published in 2015 by a Swedish group comparing intensive physical therapy plus knee replacement versus physical therapy alone. The blue group is the surgical group who had TKR plus physical therapy. The outcome variable here is the KOOS pain score, which is a frequently used pain score, and the blue group, the surgical group, clearly does better. We see the difference beginning at 3 months, and it's very clear at 6 months, and it's sustained out to 12 months. This is the very first ever randomized controlled trial of knee replacement versus PT, so it's an exciting study. It's interesting to see how much benefit there is in both groups, including the non-operative group, which was new information also, that patients with advanced arthritis could really benefit a great deal from physical therapy as they do here. And so one of the questions then is whether the benefit in the physical therapy arm will be sustained over time, and I'm sure the investigators will be following this cohort. There is an observation with of persistent pain following, especially following total knee replacement. Here's some data from the United Kingdom, a survey of 860 knee replacements, 900 total hip replacements, about 3 to 4 years after surgery, with a decent response rate. And what we see is that mild to moderate pain occurs in 20% of hip replacement and almost 30% of knee replacement patients 3 to 4 years later, and severe pain in 15% of knee replacement patients, much fewer hips. So this is a really significant problem. And here's a literature synthesis that just gives a feeling for the proportion of patients having persistent pain about a year after hip replacement. We see about a dozen studies, I meant to say knee replacement, I'm sorry. We see about a dozen studies that vary, but in general you can see that somewhere in the order of 15 to perhaps 20% of people across these studies, with just a few exceptions, appear to have persistent pain a year after knee replacement. The predictors of persistent pain include more pain at baseline, pain problems elsewhere, hip, back, depression, anxiety, catastrophizing, poor self-efficacy or confidence that patients can manage their pain and manage their rehab, high sensitivity to pain, obesity, and male sex have all been associated with persistent pain. And this is a really significant problem. If 20% of all the 600-odd thousand knee replacement patients in the U.S. have poor short-term pain outcomes, then we're talking about, over 120,000 people annually in the U.S., which is similar to the number of new cases of rheumatoid arthritis. So this is a big deal. Here's an interesting and I think a useful figure just to kind of keep in your mind. This is a group that looked at improvements in pain measured, in function measured with the WOMAC function score, and the pain is very similar following knee replacement at pre-op 12 and 24 months. And what you can see is that there's a lot of improvement in the first year, and then things are fairly stable. What the graph displays is that we have 4 groups defined by their original level of functional status, and you can see that those who started the worst at 21 improve the most up to 60, but they don't get anywhere near as high a level as those who started at 69 and made their way up to 83. And so this is a question that is really very fundamental in thinking about these procedures, whether it is in some ways preferable to operate on people with very poor levels of pain and function because we know that they will improve the most, or whether to try to intervene before people drop to those levels because we know they'll have the best long-term outcome, best long-term status. And that is an unresolved issue, I would say. The predictors of poor functional outcome is poor preoperative function, greater medical comorbidities, worse mental health and self-rated health. Obesity, there's conflicting data, and again, low volume is definitely associated with worse functional outcomes. Satisfaction is another outcome that is relevant to measure during this period because it's very patient-centered, and we can see that following hip replacement, about 8% of people dissatisfied, 89% satisfied. Knee replacement, 12% of people dissatisfied, only 80% satisfied. So the same theme, willing to have surgery, again, 96 versus 89%, where your expectations met, 78 versus 70%. So these look like very good operations from patients' point of view, but you can see that there are some patients with knee replacement who are just not doing as well, and we've seen it in all of the data that we've looked at. So to summarize, there is dramatic improvement in pain and function. We know from the trial that total knee replacement plus physical therapy is superior to PT alone, although PT alone was associated with substantial benefit in that trial. We know that knee replacement has somewhat lower satisfaction rates, somewhat less dramatic improvement in pain and function, and in fact 20% of them have persistent pain, which is an evolving public health problem. So we'll move now to long-term follow-up and think about total joint replacement as a chronic condition. What are the risks of having an implant and having to live your life with an implant? Well, one of them is revision. And so revision for infection, which is a devastating complication, occurs in a little bit under 1% of hip replacement patients, about 1% of knee replacement patients over a period of 15 years. So this is not a high risk, but it's an important one. Revision for dislocation, also on the order of 0.7% over 15 years. And this is revisions for dislocation, so it does not include dislocations that don't result in revision. I'll just pause here and point out, as many of you will know, that dislocation is a big issue with hip replacement, not with knee replacement. So these data are for hips and not for knees. Here is some data that my colleagues and I put together regarding regarding survival, not of the person but of the implant. And so we see 4 curves. The women are orange, the men are green. These are Medicare patients, so their age at the time of surgery is either 65 to 75 in the solid lines, or the dashed lines are older, 75 plus. And so I think a couple of things you can see. First of all, the dashed lines have better survival of the implant. So younger people have higher risks of revision over a 12-year period, and that's presumably because they're more active and they're loading, they're wearing down the implants more. We also see that men have higher revision rates than women, the green versus the orange, and that too is felt to be due to perhaps activity, perhaps weight or load as the risk factor. Now here is another set of data from the same data set, a Medicare data set, showing the picture a little bit differently. So let's look at the bottom rectangle. What we have here now are the patients who were 75 years or older at the time they had surgery. And what we've represented in this sort of light-colored upper right-hand corner of the box is that over time these patients die, of course, because they're 75 and they're being followed for 12 years. So 58% have died by the 12-year follow-up. The black represents the revised, and it's only 5.7% got revised, and 35% are alive and at risk of revision. And so if you were talking to patients such as the 75 and up who are thinking about having a hip replacement, one would say that, look, over the next 12 years, your risk of dying, if we want to be very realistic about it, is on the order of 60%, and the risk of revision is on the order of 6%. So revision is not a very likely risk factor as compared with the risk of dying. Most people who have a hip replacement at that age will die with their implant intact without being revised. If we go to the upper rectangle where we have people in a younger age group, 65 to 75, the story changes a little. Now, not surprisingly, a smaller number have died, 30%, and a larger number have been revised, 9.4%, and 61% are alive and still at risk. And so here what we would say is that the risk of dying is not 10 times higher, but about 3 times higher than the risk of being revised. Here's some knee replacement revision rates, and they are lower. So what we can see, these are Denmark, Norway, and Sweden, and they hover around 5% of revisions after about 10 years. So in terms of long-term follow-up, first a caveat, not all prostheses that fail get revised. Some patients are simply not offered because they're too sick. Some patients are offered revision, but they're not interested. They don't want to undergo another surgery. They would rather just modify their activities. So revision is kind of a proxy for failure. That said, about 1% per year of hips get revised, about 0.5% per year of knees get revised, and that occurs throughout the lifetime of the implant. Older patients are much more likely to die in the next decade than to have a revision of their hip replacement, and that the revision risk appears to be greatest in younger, more active, and obese patients and male patients. Also, recipients of total hip and knee replacement face risks of about 1% over the course of their implant of having an infection, having a dislocation that requires revision, having a periprosthetic fracture. So the revision risks are 0.5 to 1% per year. The specific complications of infection, dislocation, and fracture about 0.5 to 1% overall. Let's close with just some comments about alternatives. So younger patients with hip OA can consider resurfacing, and you perhaps have heard something about that. It's been very controversial because metal-on-metal designs have had high failure rates. Younger persons with new OA can consider arthroscopy. There's good data now suggesting that arthroscopy is not indicated for osteoarthritis. It is used for meniscal tear, and there's a lot of research on how useful it is in that setting. It's somewhat uncertain. Unicompartmental or unicondylar knee replacement, as well as osteotomy, can be used if only one compartment is involved. There's much more osteotomy done in Europe than in the US, and I suspect we'll see more here over time. So what are you doing? So what I like to sort of convey when I talk to patients to help them make this decision is to say, what are you doing, what are you not doing now that you'd like to be doing? What do you know about the benefits and risks of having your joint replaced, and how do you feel about those risks, and how important is it for you to be more active? Will you be more active? Some patients don't increase their activity. And then I also point out that there is a window of opportunity that patients in their mid-70s who are healthy, if they wait 10 years until their knee is really intolerable, may no longer be healthy enough to have a low-risk operation. Patients who need both knees done or a knee and a hip have to think about staging those surgeries. So those are the kinds of conversations that it's interesting to have with patients and families. So I think I'm going to stop there, and maybe, Kristen, you can just refresh us as to what the procedures are for questions.
Sure. First, thank you very much. I think that was very interesting. And for anyone who is interested in asking a question, don't forget you can press the hand raise icon on your dashboard, and I will unmute your line, or you can text me a question that I can ask Dr. Katz. The one thing that I just wanted to comment on while we wait for some questions to come in was, so much of our focus at the OA Action Alliance is on behavioral strategies and education to get people to be physically active or to lose weight. And we don't, certainly, in my own mind, I don't necessarily think about where the patient is coming from and where, in terms of surgery. We're much more on the public health side of things here at the Alliance, and I know we have a wide range of folks in the audience who are on the front lines treating patients. But, I think it's helpful to understand what the parameters of surgical outcomes are so that when we are trying to educate folks about being physically active, we take this into account and know that it's not always just a matter of getting out there and starting walking. There's so much more going on.
Yeah, I would comment, if I could, Kristen, that the issue of physical activity does not go away, and it continues to be really fascinating. One of the rationales for doing a hip replacement or a knee replacement would be to enable persons with advanced arthritis to become more physically active, and so a really fascinating area of research that my colleagues and I are involved in here in Boston is the question of whether people after these operations really do become physically physically active, and they have a window of opportunity, and oftentimes they don't, and so that's been an area to think about intervention. You know, now that you've got your mobility back, will you use it, is essentially the question. And you know, many patients are glad to have their pain relief, but actually don't resume physical activity.
Well, and that's a great lead in to one of our questions that came in is for those patients who do resume physical activity, do you place any limits, pardon me, I lost it, on, do you place limits on physical activity post-surgical? So do you allow
Yep.
tennis, golf, running? What are your...
Yeah, it's an excellent question, and I'll maybe answer more generally, you know, because this is something that I've heard a lot of different surgeons talk about, and also there are some written guidelines. So let's separate hips and knees because they're different. Hip replacements do have, as we saw in the data, a risk of dislocation, and that's particularly the case in the first year. So, so here there are some very specific limits on, for example, not crossing your legs and adopting postures, deep squatting. These are things that actually are risk factors for dislocation. So the knee replacement patient doesn't have to worry about those things so much, but the hip replacement patient really has to worry about those very specific postures. More generally, the question of how active you should be, how much you should pound on it, there's, you know, it's evolving over time, and there is no uniform agreement. Some surgeons ask their patients with a knee replacement not to ski, that the torques are just too strenuous. Other surgeons will say ski but don't take moguls, you know, to ski but kind of less vigorously, and other surgeons will say, you know, have a good time. One of the principles that I think we've learned is that an implant has a certain amount of tread life, if you will, and so the more weight you bear, the more frequently you bear it, the greater the loads, the more likely we are to see wear and have the implant fail earlier. And that's so that's probably the major concept, is that people who are super active may in return have earlier failure of the implant.
Thank you. So we have another question that came in. Much of the data presented was on patients 65 and older. Do you have any 12-year follow-up data on patients in their 40s?
That's another great question. So much of the data that I presented was from Medicare, of course, which is 65 plus, and you know, Medicare data are more readily accessible and universal, which is one of their benefits, because everybody in the U.S. is Medicare insured if they're over 65, 99%. But as the questioner points out or suggests, you know, that is not the whole story. At this point, about 60% of hip and knee replacements are done in the Medicare population, 65 plus, and a growing proportion, 40% now, but growing, are done in younger patients. There's a couple things that we know about younger patients that are really important. One is that they are at higher risk of having a revision, whether it's a hip or a knee, for two reasons. One is that obviously they have more years to live. So a 40-year-old, you know, might be looking at 45 more years, and there are very few implants that would last that long. The second is that they generally are much more active, and so they will wear the implants faster. And for that reason, there continues to be great reluctance to do joint replacement in somebody who's 40 unless there really are no alternatives, a little bit less reluctance at 50, and general acceptance by 60. That, so, you know, it's in that 50-year-old time frame that, you know, that you begin to transition from almost certainly needing to have a revision in your lifetime to perhaps not needing to have a revision. And that's the real issue, is operating early may just sort of predefine the need for a revision later.
Great. So we have a couple more questions that have come in that I would like to ask you, but because we are coming up on our 30-minute time slot for anybody who has to sign off here, anyone's welcome to stay. But just one quick announcement for our January 20th webinar with Dr. David Sabker from the Mount Carmel Clinical Cardiovascular Specialists in Westerville, Ohio. Dr. Sabker is also the founder and CEO of Walk with a Doc, which is a great community-based program to get folks walking and talk to their doctors in a very casual, low-key environment. So hopefully you'll join for that and check out our website for more information. Anyone who does have to sign off, have a great holiday. But to continue with our questions, could you talk more about the phenomenon of low-volume hospitals being a poor predictor of total joint replacement outcomes?
Sure, it's important actually because this is a modifiable risk factor. You could just go to a high-volume hospital instead. So this has been demonstrated multiple times. It's a very robust finding that hospitals that perform fewer knee replacements, fewer hip replacements, fewer coronary bypass procedures, for that matter, this phenomenon extends beyond joint replacement, tend to have higher rates of mortality and complications. And independent of that, low-volume surgeons tend to have higher rates of certain problems, not mortality, it turns out, but infection and dislocation. And so, we think that there's probably a couple of phenomena going on, and there has been a lot of research on this. One is a simple idea of practice makes perfect. For the surgeon, the one who does it many, many times, probably just gets, perfects where the cuts are made and that sort of thing. For the hospital, high-volume hospitals are able to make investments that probably really help. They have orthopedic floors where all the staff on the floor know how to treat these patients, joint replacement floors where they've seen all the complications before, can recognize them earlier and catch them before they become dangerous. So, special equipment in the operating room and on the floors that can reduce complications. So those are some of the ideas behind this.
All right, so another question is Aday from Drexel pipes up. She's wondering why the osteotomy is underutilized in the United States for knee OA.
It's a very interesting question, isn't it? Just to put it in, kind of to put some numbers to that. We do approximately 650,000 knee replacements a year in the United States, and we do about 2,000 osteotomies of the knee in the United States. So there's 300 TKRs for every osteotomy. Now, many of those TKRs, osteotomy would not have been an option because the patient has involvement of both compartments, medial and lateral. But there are many patients who have knee replacement, either unicondylar or total, for medial compartment disease, for whom an osteotomy would be an appropriate operation. The outcomes are generally good. They're not quite as good, and the rehab is at least as painful as the knee replacement rehab. So it's not, from the patient's point of view, a better operation or an easier operation. The advantage of the osteotomy is that it does not burn any bridges. You don't. So what an osteotomy does is, let's say the person has medial compartment OA. That means they're really they've been walking on the medial compartment and it's really worn out. What the surgeon does is by making some selective cuts, they reposition the legs so that they're now walking on the lateral compartment. They kind of straighten out their knee, they realign it, and where they have good cartilage, and it tends to last for 10 to 20 years. So pain relief from the patient's standpoint is really no better with an osteotomy, but it means that if they do ultimately come to knee replacement, it's a primary and not a revision. So this would be a good operation for younger people with one compartment, unicompartmental disease, either medial or lateral. Europeans use it a lot more. One of the reasons that is suspected is because there's no manufacturer who's really pitching osteotomy. The reimbursement for it is a little bit less than for joint replacement, and so that there may be subtle financial reasons, and I don't no, I can't speak very authoritatively about that, but that certainly is one of the things that's discussed. And many of the surgeons will say that osteotomy, from the surgeon standpoint, is actually a really difficult procedure. It has to be done very precisely, and it's becoming a lost art because once the number of osteotomies goes down, then the number of trainees, residents, and fellows who learn osteotomy is reduced. So it can be a self-fulfilling prophecy. So it's an interesting issue. I think that we will see a reversal, particularly as we go into an accountable care model where, provider groups are going to have to bear some of the cost of a $4,000 implant, because osteotomy is much less expensive.
Okay, and then as another question is, as a collegiate athletic trainer, I'm seeing many 18 to 20-year-olds with FAI and labral repairs compared to 10 years ago. Do you think this is a diagnosis that will help to decrease total hip arthroplasty in the future?
It's a really good question. I don't know the answer, but I think you're right on the mark that, several things about that are really fascinating. One is that I think it's not just your observation. It's really true that there are many, many more hip arthroscopies done now than there were 10 years ago as surgeons have gotten, more accustomed to doing it. And it's raised the question of, is this disease something that we've been looking at, for the last, millennium, but have not been intervening until very recently? Or is there actually a change in the epidemiology? And there's emerging evidence that because of the more intensive way that young athletes devote themselves to single season rather than 3-season sports, paying at a very high level, during the spring, during the summer, again during the fall, that they may actually what the FAI, which is the cam and the pincer lesion, these bony lesions that occur in the hip, may be responding to loading of a sort that we didn't see, 1 or 2 generations ago. It's a very fascinating story that's kind of unfolding.
All right. Well, I don't see any other questions that have come in, so I wanted to thank you again, Dr. Katz. Very helpful webinar and great question and answer session. I appreciate all of our attendees tuning in with their thoughts, and thank you very much.
Great. Thank you, Kristen, and thanks to all of you for listening. I thought your questions were wonderful, and I hope you enjoyed it.
Thank you, everyone. Have a great holiday, and we'll see you back in 2016 for our January webinar. Thanks, everyone.